high-yield clinical algorithms, and safety protocols. Let's get right into it.
So, here's the scenario. A patient is formally declared brain dead using strict neurological criteria, but the family absolutely refuses to let you remove life-sustaining measures. Maybe they're citing religious beliefs, or maybe they just feel they need more time. Medically, you know any further intervention is completely futile. So what's your actual next best step in management here?
You need to consult the hospital ethics committee. This is a classic exam trap, so watch out. Technically, once formal brain death is established, a physician doesn't legally need family permission to remove life support. But you should never unilaterally disconnect a patient when the family is strongly opposed. Bring in the ethics committee. They help facilitate an empathetic approach, meeting the family's emotional needs and helping everyone reach an understanding without instantly escalating things into a messy legal battle. Okay, shifting gears to the management of CIN3 in a non-pregnant patient. Immediate management dictates an excisional procedure like a LEEP or a cold knife conization. But the high-yield part is the system's follow-up. You have to do HPV-based testing at exactly 6 months post-procedure. If that comes back negative, the protocol dictates annual HPV testing for 3 consecutive years before they can finally return to routine screening.
Now, what's the systems level consequence of that excisional procedure we just talked about? Whenever you perform a cervical coronization for CIN2 or 3, you're physically altering the cervical anatomy. The major long-term complication you need to screen for in future pregnancies is cervical stenosis and cervical incompetence. This directly increases the patient's risk of preterm birth, premature rupture of membranes, and even second trimester pregnancy loss.
Let's look at a psych emergency. You're in the ED evaluating a 17-year-old minor. They've got active suicidal ideation, voiced intent, and a specific plan. They are at imminent risk of self-harm and absolutely need hospitalization. The legal trigger here is, do you strictly need parental consent to put this minor on an involuntary psychiatric hold?
The answer is no. You hospitalize immediately with constant one-to-one observation. Look, while getting parental consent is obviously ideal, it is not legally required to initiate a life-saving safety hold. Safety always supersedes confidentiality and any delays caused by waiting for consent. You do not wait around for a parent to show up before securing that involuntary admission when a patient is in imminent danger. When you're assessing that imminent risk, you're always weighing risk factors against protective ones. The single most critical modifiable risk factor? Access to firearms. If there are guns in the home, that drastically lowers your threshold for hospitalization. On the flip side, protective factors include strong family connectedness, religious participation, and, very notably, pregnancy and parenthood.
Here's a really challenging ethical scenario. You suspect a patient is intentionally falsifying their illness. We're talking injecting insulin or tampering with their lab samples, and they're doing it specifically to assume the sick role, not for any external financial gain. You run the labs and you have definitive proof the illness is faked. How do you ethically and safely communicate these negative test results? When you confirm factitious disorder, usually by reviewing medical records or discovering hidden supplies, your communication strategy is everything. Whatever you do, don't aggressively confront them or accuse them of lying. If you do that, they'll likely just elope and repeat the exact same cycle at another hospital. Instead, deliver the negative results as good news. Tell them you're relieved that a serious medical illness has been ruled out. This approach legitimizes their distress and lets you pivot toward a psychiatric evaluation without forcing a defensive confrontation. Now let's break down the diagnostic boundaries between a normal grief reaction and a major depressive episode. This is critical. Normal bereavement comes in waves of grief that are usually tied to reminders of the deceased person, but crucially, the patient maintains their overall self-esteem. A major depressive episode, on the other hand, involves persistent feelings of worthlessness, intense self-loathing, and a severe decline in everyday functioning. You need to be aware of a major update to the standard of care here. The old bereavement exclusion is no longer applied. If a grieving patient meets the full criteria for a major depressive episode, meaning 5 out of 9 SIGICAP symptoms for at least 2 weeks, along with severe functional impairment, you must formally diagnose and treat them for depression, using cognitive behavioral therapy and SSRIs. When it comes to matching psychotherapy modalities to their primary indications, it's all about understanding the mechanism. Cognitive behavioral therapy, or CBT, is all about challenging maladaptive cognitions, making it great for depression and anxiety. Interpersonal psychotherapy links a patient's symptoms directly to relationship conflicts. Dialectical behavioral therapy, or DBT, is your absolute first-line go-to for borderline personality disorder because it specifically targets and improves emotion regulation. And biofeedback, reserve that for prominent physical symptoms and pain disorders.
All right, let's talk pain management and safety. Say you've got a patient with severe refractory chronic pain and you need to initiate long-term opioid therapy. The risk of misuse, diversion, and toxicity is obviously huge here. So, what specific systems-based practices are legally and ethically mandated before and during this therapy?
There's a strict 4-step sequence you have to follow. Step 1, you actively screen for misuse risk factors, like a history of substance use disorder. Step 2, you have to query the PDMP, the Prescription Drug Monitoring Program database. Step 3, set up a controlled substance agreement that restricts the patient to just one prescriber and one pharmacy. And step 4, you need to perform random urine drug screens during follow-up visits just to verify compliance.
Now contrast that with acute nonspecific back pain, where the protocol strictly avoids opioids. First-line management here is all about non-pharmacologic measures. Specifically, you want them to maintain normal, moderate activity because bed rest is totally contraindicated. You'll start them on NSAIDs, like naproxen or ibuprofen. You only move to second-line non-benzodiazepine muscle relaxants if the pain is severe and refractory.
Let's look at perioperative prevention. You're seeing a 55-year-old patient with an active smoking history who is scheduled for elective surgery. This patient is at a high risk for postoperative pulmonary complications. We're talking atelectasis, bronchospasm, pneumonia, or needing to be on a ventilator longer than expected. What's the mandated prevention strategy here? Since it's an elective surgery, you have the time to optimize the patient. The evidence-based strategy requires them to stop smoking ideally 4 to 8 weeks before the procedure. This gives their airway cilia time to recover and cuts down on sputum production. Then, post-operatively, the protocol mandates aggressive pain control, deep breathing exercises, and immediate use of an incentive spirometer to keep those airways propped open and prevent basal atelectasis. Moving on to the ICU Liberation Protocol. This is a standardized strategy built to promote recovery from critical illness and ward off long-term morbidity. It mandates daily sedation vacations and spontaneous breathing trials. On the physical side, it requires early mobilization. Cognitively, you need to facilitate normal sleep-wake cycles. And from an iatrogenic standpoint, you have to proactively remove any unnecessary lines, drains, and urinary catheters to prevent hospital-acquired infections. If ICU liberation fails, the patient can develop post-intensive care syndrome, or PICS. This shows up as neurocognitive decline, psychiatric issues like PTSD, and severe physical weakness. The absolute necessity here is immediate, multidisciplinary physical and occupational therapy. It's also vital to set realistic recovery expectations right out of the gate, because most of these patients are going to need long-term home care and may never actually return to work.